Is CAR T a one-time treatment?
Typically, CAR T cell therapy is a one-off treatment, and most of the trials that have been performed so far give CAR T cell therapy as a single infusion. Now, within myeloma, unfortunately, we are seeing that patients do relapse following CAR T cell therapy, which is then asking the question, can you reinfuse patients? So far, we don't have much data. The little data that we have is that repeat infusion with exactly the same CAR T cell has not been very effective. So I think if you are going to have a second CAR T cell infusion, you may need to think about switching the antigen or adopting a slightly different approach to make it more effective. What we are also, however, looking at is to give maintenance treatment following CAR T cell infusions to try and really extend that progression-free survival, and in multiple myeloma, try and get that cure that we're desperate to achieve. Now, so far, we really don't have any data about giving any maintenance treatment after CAR T cell therapy, but it does make sense to give some of the immune modulatory drugs. This may include daratumumab or lenalidomide, which are standard drugs that we give for myeloma, but they modulate the immune system to try and enhance those effects of those CAR T cells. So those clinical trials are being planned, and we'll have to wait to see what some of those results are like.
So I think that's an excellent question, when we don't fully have the answer to yet. Right now it is. So right now it's a one-time treatment. Patients have their cells engineered in the lab, and then they receive a short course of lymphodepleting chemotherapy to kind of prepare their body and bone marrow and the immune system for the CAR T cells, and they get that as a one-time infusion, and then we just watch after that. I think one of the areas of sort of development going forward is figuring out whether or not that's the right approach, whether we should consider giving multiple infusions over time, whether we should consider combining CAR Ts with other treatments to improve the activity or efficacy, whether we should combine two different CAR Ts together, things like that. So I think it's an area of active research, but right now it's a one-time treatment.
Where can I learn more about CAR T treatment?
Studies have shown that educated and empowered patients often have better outcomes. HealthTree University is the first and only free, comprehensive curriculum for patients and caregivers. Create a free account to gain exclusive access, where you can watch our newest unreleased videos, easily explore topics through our organized courses, and assess your knowledge with interactive quizzes. Visit HealthTree University and become an empowered patient today.
Is CAR T a one-time treatment?
Yes, for now it is. The way that it is approved, it is a one-time treatment. But as we all know, it's not a curative treatment. While it gives you, a really good response, a durable response, more so than we would have with any other treatments at this time, for example, in the fifth-line setting, there's still need for improvement. Again, as of right now, the insurance commonly authorizes one CAR T treatment. However, in our U.S. Multiple Myeloma CAR T Consortium, we have looked at patients who have had multiple CAR Ts. For example, if somebody had received CAR T on clinical trial, whether that was a CAR T using your own cells or a CAR T using somebody else's cells, what we call allogeneic CAR T, they have been subsequently treated with a commercial product, and our experience is very limited with this. It was actually only about 5 patients, but we saw that the response rate was essentially over 80%. For now, the way it's approved, it's a one-time treatment, but in the future, there is a possibility, especially as we get new targets and we learn more about sequencing of the agents we have available now, certainly could be a possibility. But we're seeing good responses at present time.
So CAR T is a genetically engineered lymphocyte, and when they're given, they're supposed to be a living drug, and they go after the cancer cells, they proliferate, they replicate, they release the cytokines and kill the cancers. And if the patient does go into remission, theoretically they should go into memory state or hibernate, and in case there is a relapse, they're supposed to wake up and supposed to fight the cancer back again. Unfortunately, one of the problems that we are seeing in CAR T is fantastic response, but it is not persisting. And that could be from the T cell senescence, and they get fatigued. So there are now trials going on in different aspects how to maintain the persistence of the CAR T in the system. Now in clinical trials, we have found CAR T by flow cytometry and other techniques many months and years after the initial first time infusion of CAR T. But we should be expecting to see that in majority of the patients active, ongoing in the memory system. For that, aliquots of CAR Ts have been proposed. Also, CAR Ts associated with PD-1 inhibitor that actually accentuates the effect of the CAR T, that has been proposed. So I think the future is very bright in CAR T therapy in general in cancer.
We don't know yet if repeated doses are going to be the way to go. It kind of makes sense, but we also don't know if the cells are going to mutate their BCMA so it no longer binds. And with CD19, we have a lot more experience about mechanisms of resistance. In some cases, CD19 disappears from the tumor. It gets modulated off, where you don't have the target anymore. They may be different in BCMA, we don't know. The tumors unfortunately get very smart, and they figure out ways to circumvent or get around the CAR T cell. And we just don't have a lot of experience in myeloma. Some patients still express BCMA, sometimes they have lower levels. It also turns out BCMA is shed by the myeloma cells. So if there's a ton of BCMA protein in the blood, it may block the CAR T cell. Why? Because it's binding to the BCMA receptor on the T cell. So these are all sort of multiple approaches to trying to sort out what we're doing with this. So it may be you give multiple infusions. It may be you only give one, the laboratory people figure out a way to make the T cells live longer in the patient so that you don't have to give multiple infusions. You may want to optimize the target. There are some that are using different types of binding to BCMA, different types of receptors that may have better affinity, or bind two different parts of BCMA so you can decrease resistance. These are all new questions that we're going to answer in the future.